Hello, my name is John Boone. I'm a medical physicist at UC Davis Medical Center, and the title of this talk is Variation in CT Dose, One Size Does Not Fit All. So we will start with some front page news from a decade or more ago, and then we'll talk about adjusting techniques to the patient size, and then tube current modulation, and then something that's been discussed more extensively in another talk, size-specific dose estimate, and then a brief summary. So front page news. So on slide 4 we show something from USA Today, which was on the front page, entitled CT Scans in Children Linked to Cancer. This was run January 22nd, 2001. Of course, this did not do radiology too many favors in terms of the eyes of the public, and obviously it stimulated a lot of discussion within the radiology community about right-sizing the dose for pediatric patients in general in CT. So exactly 7 years after that, January 22nd, 2008, the Alliance for Radiation Safety in Pediatric Imaging started the Image Gently campaign. Well, I'll just note that the size issues are really not just pediatric. There's a wide range in adult size as well, as shown on slide 6. And this has sort of stimulated the Image Wisely campaign, which is essentially the mirror image of the Image Gently campaign, except for adult population. So this issue of radiation dose in computed tomography has been a popular issue both in the lay press and in the scientific literature. And on slide 7 we see the number of scientific articles published on this topic as a function of year of publication. And after that 2001 article in the front cover of USA Today, we see really an exponential growth in the number of patients or papers on this topic, and there's no end in sight, it would appear, from this graph. So let's talk about adjusting techniques to patient size. And shortly after this USA article came out, that was long before CT scanners had what we now know today as tube current modulation. And so in my group, myself and colleagues wrote a paper that was published in 2003, not long after the stir that was promoted by that USA Today article. And you can see the title is Dose Reduction in Pediatric CT, A Rational Approach. And after that article, people wanted to turn down the dose levels, but they didn't really, at least as what we perceived, know exactly what to turn down and how much to turn it down by. And so we, on slide 10, you can see some pictures. I had 6 different polymethyl methacrylate cylinders machined, and we used these and made measurements of both CTI dose, and we also measured the noise as a function of dose, or MAS, as you can see on this slide. And we compiled all this data with essentially some recommendations for how you can turn down the relative MAS and maintain constant contrast to noise ratio. This is shown on slide 11. And these curves actually were appropriate. They maintained similar CNR based upon our calculations. After this paper was published, we learned that the needs for contrast to noise ratio in pediatric patients are probably greater than in adult patients, and so these technique charts would be considered quite aggressive in terms of dose reduction. The radiologist would have to really live with much reduced noise fidelity, and so even just 1/3 of, if you were to take these recommendations and multiply them by 0.33, you would still get good dose reduction and still maintain higher image quality. And this is mentioned in this paper. So, of course, that was our work. Other people around the country and around the world also were working on this in the early years of the 2000 decade. And these are just some a picture of some phantoms at the Mayo Clinic in Cynthia McCullough's group, where she made comprehensive measurements of dose as a function of all these patient sizes. Well, fast forward to today, and we really have scanners that address this need, and virtually every modern CT scanner has tube current modulation along with automatic exposure control. And so in mammography or in radiography, this is usually referred to as phototiming. So let's talk about tube current modulation. So there's an angular component to tube current modulation, as shown here in slide 14. And as the tube rotates around the patient, we can see that the attenuation of a patient is not completely cylindrical, varies depending upon which projection through the patient the tube is making. And so what angular tube modulation does is when the projection through the patient is thick, it turns up the MA, and when that projection through the patient is thinner, it turns down the MA. This actually equalizes the image quality, so it turns out that this is a form of dose reduction that doesn't take a significant hit in terms of image quality loss, and so this is definitely the right thing to do, and angular-based MA modulation should be used in most cases, especially in the body and even up in the head and neck area and chest as well. So there's another component of MA modulation along the Z-axis, as shown in slide 16, and this just shows that not only does the X-ray MA vary as the tube rotates angularly around the patient, but of course as the patient is moved in and out of the gantry, the patient has different widths of their hips versus their chest and up into their lungs, and so the Z-axis modulation takes effect along this axis, and so these combined effects really are Z-axis and X-ray tube angular modulation take place. So on slide 17, we show essentially the MA map overlaid onto a patient, and you can see constant MA is the red line, reduced dose based upon a scout is the yellow line, and the blue line shows both the angular modulation and the Z-axis modulation. So in most scanners, or in many scanners, the MA modulation scheme is based upon the localizer view. Some scanners, specifically Siemens scanners, modulate the MA based upon the previous scan, so 180 degrees prior to the current location for the current acquisition is essentially an equivalent view, and the Siemens scanners use that to adjust the MA very, very dynamically. So CT dose modulation using automatic exposure control techniques here really can lead to reasonable dose reductions on the order of 10 to 40% compared to constant MA, and that depends upon what part of the body we're talking about. Slide 18 shows an MA modulated scan that I evaluated through the lungs and abdomen and down into the pelvis, and you can see on this slide the various MAS values that were used as the scanner went from up into the upper torso down into the pelvis regions. And as you would expect, the areas that are easier to penetrate use less MAS, and the down in the pelvis, which is larger in thickness, the higher MAS values were used. So it has to be noted that automatic exposure control really involves two aspects of dose selection: the overall MA selection, which is very much like phototiming, and also the tube current modulation scheme along the length of the body and angularly, as we've discussed. So the overall MA selection is an important aspect, and on slide 19 we show two different versions of this between the yellow line and the red line. The red line shows a much lower MA, much lower dose setting, and the image quality will be reduced as well. But it also needs to be noted that when you use automatic exposure control in any radiographic procedure, especially CT, you are handing the responsibility of selecting the dose for that patient, for that scan, over to the CT scanner. So you better know what you're doing. You better know how your scanner is responding to the selection control, to the tools that are used, to the parameters that are used to adjust the automatic exposure control. And there are some unintended consequences of tube current modulation, and these were the well-known cases of epilation that occurred in Southern California. And these were under tube current modulation schemes that may have not been selected appropriately, or other issues that are It's a subject of lawsuits, so too much cannot be said about that at this point in time. But a large number of patients did experience epilation as a result of these procedures, which were CT brain perfusion studies, which are high-dose examinations, really 40 CT scans performed serially in 40 seconds typically. So this is a high-dose procedure when done well. It's even a higher dose procedure when not done well. And of course that provoked a lot of emphasis in the press, as this Sacramento Bee article from 2009 shows on slide 21. So enter this. Not only do we need to adjust the technique factors to accommodate the size of the patient, but if we really want to estimate the radiation dose to the patient, we need to take into consideration their size as well. And this leads to this size-specific dose estimate. After the accidents, the AAPM put on a CT dose summit in Atlanta of 2010, and I was there and was making some final remarks, and they were having a discussion with the 200 or 300 people that were in attendance, and actually a number of pediatric radiologists from the Image Gently campaign mentioned earlier engaged myself and others, and we made a promise to the Image Gently people that the medical physicists would come up with some way of adjusting dose to better predict the dose or calculate the dose in pediatric patients. And that led to a very rapid group of people coming together and working on what became known as Task Group 204. And the general sentiment is illustrated in slide 24, where if the CT scanners do put out a CT dose metric titled CTDI-vol, which has been discussed extensively in this virtual conference. And the problem is that number is really the dose to a very large piece of plastic, a 32 centimeter diameter polymethyl methacrylate. And for patients, especially smaller patients, the relative radiation dose to the patients is much higher for the same technique settings. And so the CTDI-vol does not tell the story for especially smaller patients. So the fundamental findings of the TG204 group are shown on page 25, and this shows essentially a conversion factor as a function of effective diameter. I just show this to illustrate the point. There are other talks on this topic specifically, and so these are the results of AAPM AAPM report number 204. And the title slide is shown on slide 26. So the results of AAPM report TG204 are discussed in the UC Virtual Symposium in RS 011, that lecture. I just show you some additional data that I've performed here with my colleagues. based upon some data that we accumulated on one CT scanner in abdomen pelvis CT scan for about 200 patients. And on slide 28 we see the CTDI vol as a function of average diameter, and this shows that the tube current modulation and automatic exposure control is working as it should. The dose is turned up, the CTDI vol is turned up as the patient gets bigger, or said differently, it's turned down as the patient gets smaller. People have criticized the radiology community for having a very wide range in CTDI vol, but I'll just illustrate that if we subtract the best fit line here on slide 28 from the actual data points, we get the residuals. And so what we're doing here is we're taking out the size of the patient as characterized by the average diameter of the patient, and when we do this, the variance actually goes down by a factor of 7 when we take into consideration the diameter. So there's room for improvement for sure in our protocol selection in radiology, but with tube current modulation and automatic exposure control, we really the range in CTDI vols are largely due to the changes in the diameter and the size of the patient. So this slide shows essentially the difference between the SSDE, the size-specific dose estimate, and the recorded CTDI vol as a percentage as a function of the average diameter of the patient. You can see that CTDI vol is right on for a patient who's about 36 centimeters in diameter, but as that patient diameter or average diameter decreases down to say 25 centimeters, the actual dose of the patient, the SSDE, is on the order of 45% greater than what the CTDI vol reports. So in summary, what we're talking about here is the variation in CT dose, and one size does not fit all. And what we need to do is really right-size the protocol to the patient and to the task at hand, to what the CT was ordered for. And specifically, the CT technique should be adjusted to the patient size. We've learned that CT dosimetry is also very dependent upon patient size, and therefore the patient size should be considered, and that leads to the SSDE metric. And CT image quality needs vary in pediatric imaging. That is, the contrast to noise ratio requirements are higher because of the lower amount of organ fat and other issues in the pediatric patient. Thank you for your attention.